Good afternoon, ladies and gentlemen. HipecTreatment.com would like to welcome you to this Hipec Facebook Live presentation entitled Hipec in Clinical Practice, Why and When. Our presenters are Dr. McNally and Dr. Hadley Freeman, both board-certified surgical oncologists at St. Luke's Health System, Kansas City, Missouri. My name is Glenn Keeling, and I will be your event moderator for the Q&A session following Dr. McNally's and Dr. Freeman's presentation. You will be able to message your questions using the Zoom Q&A option. I will present your questions to Dr. McNally and Dr. Freeman following their presentation. The Hipec Facebook Live and Q&A session will be recorded for future viewing. At this time, it is my great pleasure to present our Hipec Facebook Live presenters, Dr. McNally and Dr. Freeman.
Wonderful. Thank you so much. So first, I wanted to address a few common misconceptions of cytoreduction and Hipec, one of which is that it's a misconception that patients receiving this type of treatment always recur, which is not the case. This can be curative in certain instances. Morbidity is prohibitively high. That is also not necessarily true. These procedures range in morbidity and complexity depending on the type and extent of disease, so it's very different for every patient. Some have labeled this as an intervention seeking an indication, which is also not true. There is a lot of substantial data that exists that proves that Hipec is a very reasonable, safe, and effective treatment for many cancer types, which are metastatic to the peritoneal cavity. And so I just wanted to debunk a few of those misconceptions, and we'll go through some of these things as we go through the talk. So which patients are candidates for cytoreduction and Hipec? This treatment is largely devoted to patients with isolated peritoneal metastases. And why? The purpose is for regional control of peritoneal metastatic disease. So in terms of the types of malignancies that are effectively treated with cytoreduction and Hipec, this includes tumors of the appendix, so appendiceal mucinous neoplasms, as well as appendix cancers like adenocarcinomas that have mucinous histology, as well as some select colorectal cancers, epithelial ovarian cancers with peritoneal spread. There is emerging data for gastric cancer with peritoneal spread, as well as malignant peritoneal mesothelioma. And as I mentioned, regional control of the peritoneal metastatic disease is based on the quality of the surgical cytoreduction, and the heated intraperitoneal chemotherapy, or Hipec, is an adjunct treatment to that. Some of you may have been told or diagnosed with something called pseudomyxoma peritonei, which is kind of an umbrella term for a clinical syndrome, which is characterized by progressive accumulation of mucinous material within the abdominal pelvic cavity. And this can result from different types of tumors or cancers. The prognosis can vary depending on the tumor histology and pathology. But so this is an umbrella term, but that's what that means, is that the abdomen and pelvis can be filled with a gelatinous material. And there are multiple causes for this, but they are largely mucinous tumors, which have spread to the peritoneum, resulting in the mucin filling the abdominal cavity. This is very rare. The incidence is approximately 2 to 3 cases per million people per year. Most commonly, this originates from appendix tumors. So you may have heard of appendiceal mucinous neoplasms, like a low-grade mucinous neoplasm or a high-grade mucinous neoplasm of the appendix, as well as appendiceal mucinous adenocarcinoma. The second most common primary site would be that tumors originating from the ovary, mucinous tumors from the ovary. And then more rarely, this can occur from tumors of the colon or rectum, the stomach, pancreas, small intestine, and liver. So the rationale for this type of treatment, we know that resection of metastatic disease is effective in other types of cancers, such as colorectal liver metastases. And so this is just a different type of metastatic spread. So therefore, the data shows that resection of metastatic deposits to the peritoneum can be very safe and effective for certain types of cancers. Why not just give conventional chemotherapy? This is a question that is asked very commonly. Conventional chemotherapy is not as effective. It doesn't reach the tumors of the peritoneal cavity, or excuse me, the abdominal cavity and the peritoneum as well, due to a certain barrier, which is the peritoneal plasma barrier. So the chemotherapy, doesn't reach those tumors as well, so it decreases its effectiveness. Whereas Hipec or intraperitoneal chemotherapy will target those tumors directly by direct contact. What does cytoreductive surgery entail? This includes essentially removal of all of the tumors in the abdomen and pelvis. This will commonly include removing the peritoneum or the inner lining of the abdominal cavity, from the upper abdomen, the middle abdomen, the lower abdomen, and pelvis, as well as oftentimes we have to remove the peritoneum overlying the mesentery, which is the blanket of fatty tissue that has the blood flow and the lymphatic channels going to and draining the small bowel and colon. And then oftentimes this will also include visceral resections. Not all of these are included in every operation, but they can include resection of the colon or rectum, small bowel, spleen, stomach, the liver capsule, or a portion of the pancreas. Determining the extent of disease is very important in selecting patients who we think will benefit from cytoreduction and Hipec. And one of the components of your evaluation for surgery will be your provider determining the peritoneal cancer index, or PCI score. And what this is a score that quantifies the extent and distribution of cancer within the abdomen. So where are the tumors and what is the extent of the tumor burden? And ultimately, what is the likelihood of achieving a successful cytoreduction? This is a score that we can complete by use of MRI, or more commonly, your surgeon may perform a diagnostic laparoscopy to actually put a camera into the abdomen and calculate this score. And then this is just a breakdown of the areas that we evaluate over here on the right, and tumor burden receives a score, and then we add up the scores to give you a final score. And the threshold for surgery is very different depending on what the underlying pathology is in terms of what is an acceptable score to proceed to cytoreduction and Hipec. The completeness of cytoreduction, or essentially the quality of the operation, how successful was the operation, depends on how much tumor was able to be removed. So the goal is to remove all visible tumor, or all visible tumor up to 2.5 millimeters. This is a study that was completed back in 1995, and this is a survival curve comparing patients who had complete cytoreductions up to 2.5 millimeter tumors versus those with incomplete cytoreductions. And you can see that there is a wide spread there between the survival curves. So patients that had tumors 2.5 millimeters or less remaining in the abdominal cavity upon receiving the heated chemotherapy fared much better than those who had remaining tumors larger than 2.5 millimeters. I will say there is a caveat here. Some pathologies will necessitate a CC0, or no visible tumor remaining in the abdomen, to be considered a successful cytoreduction or a complete cytoreduction. And some pathologies allow for tumors up to 2.5 millimeters to be considered a complete cytoreduction. And the purpose of this is because the penetration or the depth of the chemo into the tumor is it ranges depending on the chemotherapy, but usually not more than 4 millimeters in depth does the chemotherapy penetrate. So this is to allow for successful penetration of the chemotherapy with any remaining tumor. A little bit about the heated intraperitoneal chemotherapy, or Hipec. This chemotherapy is perfused directly into the abdominal cavity and targets the peritoneum, or the lining of the abdomen. It's perfused at a high temperature for a set amount of time. This is institution dependent and protocol dependent. The chemotherapy reaches the abdominal cavity and its structures, and it's limited in its systemic absorption by the peritoneal plasma barrier. So you can have very high doses of chemotherapy directly targeting the tumor cells within the abdomen, but you don't receive severe systemic toxicity because the dose of this chemotherapy reaching systemic circulation is very, very low. Like I said, the chemotherapeutic agents differ depending on your type of cancer, the institution, and the protocols at that institution. The chemotherapy is perfused after the tumors are removed, or after the cytoreduction. These drugs are perfused typically from 30 to 90 minutes. Some protocols are up to 120 minutes, depending on the institution. And there are open versus closed techniques. And then furthermore, this can be completed robotically or laparoscopically, depending on surgeon preference, extent of disease, and details of the operation.
All right. Thank you, Dr. Freeman. We would like to talk about a few additional factors in terms of our patient selection and other opportunities more specific to our program. First, I would like to just mention that there are some other forms of intraperitoneal chemotherapy aside from Hipec. One is standard intraperitoneal chemotherapy that's delivered typically through a port-type device. There's a newer therapy that is available called Hipec, which is actually pressurizing that chemotherapy into the peritoneal cavity. And then there is chemotherapy that's administered into the abdominal cavity shortly after that cytoreductive surgery, also known as Epic. What we like to evaluate patients for in terms of determining whether or not they are a candidate for cytoreduction, in addition to their tumor biology and their extent of disease, we also look at their overall workup, looking at their labs, particularly if they had chemotherapy before, how that's affected their overall function, what the imaging looks like to make sure there's nothing in addition to the peritoneal disease, such as liver or distant metastatic disease in the lungs. If they've had any other procedures, if they've had prior minimally invasive or open procedures. And then we also want to look to make sure that the patient is fit for surgery. A lot of people have heard of rehabilitation after surgery, but we also like to look at prehabilitation, meaning making sure that the body is ready for the surgery from a nutritional standpoint, from a functional standpoint, and also ensuring that there's no baseline cardiopulmonary disease that would be prohibitive to undergo this surgery and the extent of recovery. If it's a patient with certain disease processes, they also may need to complete a course of chemotherapy and ensure response to this. This is not applicable to all patients, but this is something we also look for prior to undergoing cytoreductive surgery in Hipec. After the surgery itself, typically in our program, the patients are admitted to the ICU at least for the evening after surgery, especially with the typical length of the surgery and some fluid balance shifts that occur afterwards. At our particular program, we have trained surgical critical care intensivists who are well versed in taking care of these patients, particularly for the first 12 to 24 hours, when some of those factors can be more integral to the patient's care. That fluid status is monitored, their kidney function and urine output is monitored. We typically will place what's called a nasogastric tube, or a tube through the nose into the stomach, because a lot of patients will get something called an ileus, where the bowels are sleepy after this surgery because of the manipulation during the cytoreductive portion of the surgery, and also because of some irritation from the Hipec. Typically, a lot of patients will also receive parenteral nutrition or nutrition through the IV, especially if we do anticipate that longer ileus or a delayed return to bowel function. We also at our program work together with our pain management team, with our anesthesia service, and we'll use multimodal pain control, including sometimes epidurals or nerve blocks, other medications like ketamine and ketamine and lidocaine drips, to take care of patients' pain afterwards, so that we can get patients up and moving to help enhance their recovery. Typically, hospital stay will last a minimum of a week to 2 weeks, depending on the extent of the cytoreductive surgery, how the patient is overall done, how that bowel function is returning, and if they have any other complicating factors with their overall health status. Overall recovery, I typically tell people it takes 6 or 8 weeks to feel 80 to 90% themselves. For some patients, it can even take upwards to 3 months to recover from this surgery. Other things that we look at when we're determining if somebody is a candidate for cytoreductive surgery, as we talked about earlier, there's different pathologies that can result in peritoneal metastases, and some of those features will help us know if we can perform that complete cytoreduction safely. If the patient has a particular type of tumor where systemic chemotherapy is used before surgery, we assess their response to this, whether it's on imaging or their clinical response. There are tumor markers and circulating tumor cell tests that we can also use to determine if there's been a response to the chemotherapy, which then helps us know that we can be more aggressive and typically proceed with cytoreductive surgery and Hipec. Either with specialized CT or MRI imaging or a diagnostic laparoscopy, that extent of disease is assessed and that PCI score is determined, and that helps us also determine if we can safely proceed with a complete cytoreductive surgery in Hipec. As I mentioned earlier too, their overall performance status, their nutritional status, or their health conditions will help us determine whether or not their body can handle that. The timing of the procedure depends on a lot of factors. For some of the diagnoses, surgery is the first step in the patient's care plan. For other diagnoses, particularly like appendiceal adenocarcinoma or colorectal adenocarcinoma, or sometimes even ovarian cancers, patients will receive what we call neoadjuvant or chemotherapy prior to any surgery. For some particular circumstances, immunotherapy can also be in addition to or instead of traditional systemic chemotherapy. After the surgery, for some diagnoses, patients will still require chemotherapy or immunotherapy following the procedure, even if we consider the procedure to be a complete cytoreduction or successful procedure. What is the goal for cytoreductive surgery in Hipec? That is a successful surgery. That complete cytoreduction of either a score of 0 or 1, again, less than 2.5 millimeter sized tumors remaining in the abdominal cavity, or less, is what our goal is. That's when we know we can really affect the patient's overall outcome by removing all of those visible tumors and then following this with Hipec. And this is because our intent is curative for a lot of patient diagnoses, or long-term remission, meaning a delay in recurrence for several diagnoses. And then in some circumstances, we have to focus more on palliation of symptoms, and that's our primary goal of the procedure. Some of the predictors of benefit, in addition to the candidacy points that we discussed earlier, are the tumor histology and grade, that PCI score, and again, that completeness of cytoreduction. So just looking at some of the data in very broad strokes for some of the main diagnoses that cytoreductive surgery in Hipec is applicable for, includes appendiceal mucinous neoplasms, both low and high grade. Cytoreductive surgery in Hipec is the standard of care and has shown an improved overall survival with an opportunity for cure. For malignant peritoneal mesothelioma, again, we see an improved overall survival if a complete cytoreduction in Hipec can be delivered. And in addition to that, there are other adjunctive, both post-op chemotherapy systemic-wise, as well as intraperitoneal chemotherapy given for this diagnosis. For ovarian cancers, particularly epithelial, this is applicable for stage 3 patients. Typically, patients are given neoadjuvant chemotherapy, then followed by cytoreductive surgery and Hipec, and we see an improved overall survival in this scenario. For colorectal cancer and appendiceal adenocarcinoma, the data really is mixed and it's context dependent. There are several studies that look into when and how this should be done. This can be dependent on the institution itself and their prior experience with that. In gastric cancer, this is something that is an emerging technique for this, where patients can even undergo Hipec prior to any major surgery, or as an adjunct to systemic chemotherapy to determine if we can, or to try to get these patients to an eventual surgery for their gastric cancer. But this is in highly select patients and a lot of times on clinical trial protocols. Lastly, some of the key points that we would like to make is that there is improved regional control of peritoneal cancer with cytoreductive surgery and Hipec. In some diseases with carefully selected patients, this can lead to an improved overall survival and opportunity for cure. As we've mentioned, that complete cytoreduction is critical. There's really not a survival benefit that has been shown if there's an incomplete removal of the tumor burden. And so that patient selection is critical to determine whether or not that complete cytoreduction can be safely achieved. Hipec is used for that adjunct after the complete cytoreduction to treat anything that's microscopic. If there's something there that we can't see or feel, that is the purpose of Hipec. And while cytoreductive surgery can be very morbid based on the extent of the disease and which organs are affected, Hipec does not add a significant morbidity on top of that. And lastly, the care of patients with peritoneal cancer is very complex and nuanced. Referral to an expert center is essential, making sure that the treatment is done by a program with a lot of experience. Our program is at St. Luke's, part of the BJC Health Consortium in Missouri, primarily. Our main hospital is located in Kansas City, Missouri, at the St. Luke's Cancer Institute. We are affiliated with the University of Missouri, Kansas City School of Medicine. We work with residents and fellows through our program. Our Hipec program was established about 14 years ago and is currently the only center in the region. We're a high volume center and able to perform some of these in select cases, both robotically and laparoscopically. We like to pride ourselves on a patient-centered approach and making sure that we take all of those complexities of the patient's care into consideration when deciding on cytoreductive surgery and Hipec. And we do have a multidisciplinary GI tumor board that meets weekly that consists of surgical oncologist, radiation and medical oncologist, pathologist, radiologist, interventional radiologist, and transplant surgeons when deciding upon these patients' care treatment plans. And thank you so much for all of your time, and we'd like to open this up for any questions.
Dr. Freeman, Dr. McNally, I want to thank you for a great presentation. We do have a few questions. What questions should I ask my surgeon during a consultation for Hipec?
When a patient first establishes with a Hipec surgeon, I think it's important to ask questions about the workup. Is this type of tumor typically treated with cytoreduction and Hipec? What kinds of things are going into the decision about their surgical candidacy? And in terms of those decisions, what does that mean for the patient? What types of things can the patient do to prepare themselves for the surgery? That's very important too. Not only is the disease responsive to cytoreduction and Hipec, but is the patient medically and functionally fit for the operation? What does the surgeon expect for the operation to entail? This can be very different from patient to patient. So it's really dependent upon where the disease is, the burden of the disease, and patient factors as well. Another question to ask would be, the duration of the operation and what the expected post-operative recovery course is going to look like. Some patients, are in the hospital for up to a couple of weeks, if not longer, and need some sort of post-hospitalization, rehabilitation or a skilled nursing facility or something. It depends on their overall status. But depending on the length of the operation and what all was removed, and what the recovery period is going to look like, that can be very variable between patients. So I think that's a really important question to ask. And then another would be their overall prognosis. Like we mentioned, some tumors or some cancers, I say tumors because some of these are not technically malignant, but they are treated like a malignancy because they have some characteristics where they can behave like a malignancy. And so overall prognosis is very important to ask about, because if a patient is considering undergoing this type of an operation, you want to make sure that it's worthwhile and that it's beneficial. So, is the treatment intent curative? Is the treatment intent long-term remission, or is the treatment intent palliation of symptoms? I think that's another good question to ask.
Okay, here's another question that came in. I had peritoneal spread and had Hipec. I'm NED. Hopefully still, last scan was yesterday. Why did it skip my liver?
Yeah, that's a good question. Depending on the initial pathology, some of these disease processes, such as appendiceal mucinous neoplasms, typically just involve the peritoneal cavity and don't have that invasive component. And that's because they're more of a cancer-like behaving process rather than an actual malignancy. Now, other malignancies that involve the peritoneal cavity, like appendiceal adenocarcinomas and colon adenocarcinomas, will sometimes invade through lymphatics or blood vessels, or sometimes have silent perforations. And these are different ways that cancers can spread. The ones that are involving the peritoneal cavity may have had a silent perforation at some point and created that involvement of the peritoneal cavity without having that invasiveness into the lymphatics and bloodstream to cause the distant metastatic disease. But the presence of distant metastatic disease, such as in the liver or the lungs, those are times when systemic chemotherapy is more appropriate most of the time, as opposed to the cytoreduction surgery in Hipec.
Okay, last question. Is it possible to biopsy spread disease?
Yes, it is possible to biopsy disease which has spread. There are different avenues for biopsy. It depends on where the disease is located, the size of the tumor, and any surrounding structures. So I think usually the question is, what is the safest method to biopsy? And, what is the level of invasiveness of the biopsy? Some patients are able to receive a percutaneous biopsy with a needle. Some patients, depending on where their disease is, require a diagnostic laparoscopy or an actual surgical procedure for us to go in and look inside the abdomen and surgically biopsy a tumor. Some patients, we achieve the diagnosis through aspirating ascites or fluid in the abdomen. So there are different methods to biopsy, but oftentimes, yes, these tumors can be biopsied.
Can Hipec be done laparoscopically?
Yes. So currently in our program, we do include robotic and laparoscopic cytoreductive surgeries and Hipecs in limited situations. So as an example, if the patient had a low-grade appendiceal mucinous neoplasm diagnosed and there's very limited tumor burden, then the majority of that cytoreductive surgery is able to be performed minimally invasive. And then there are catheters that can be placed a few different ways to also accomplish that in a less invasive fashion, to help enhance the patient's recovery and speed up that process overall, less pain with smaller incision. So that is a possibility in particular circumstances when there's a really low tumor burden.
Last question. What is the quality of life like post-Hipec?
I think that question is very difficult to answer because it's going to be very different patient to patient. It really depends on what your functional and performance status is going into the operation, age, extent of disease, what type of pathology is your tumor, is it a low-grade mucinous neoplasm versus a more aggressive type of tumor such as adenocarcinoma? What effect has the tumor and/or any sort of chemotherapy that patient has received? What effects have those done to the body before surgery? So a lot of it is based on what your body is going into the surgery, and then what all has to be done in the surgery. If you're requiring a multivisceral resection or resection of multiple parts of organs to remove the tumor, and it's a very long procedure, a long time under general anesthesia, and potentially a long post-operative course in the hospital, that's going to take a lot out of a patient. If it's a patient that has a very low volume of disease and didn't require chemotherapy and undergoes a shorter procedure with potentially a less invasive approach, even like robotic or laparoscopic, or a lower tumor burden requiring a less surgery, so to speak, and they have a shorter hospital stay, their recovery is going to look a lot different. So that's imperative that you ask your Hipec surgeon about that when you're considering undergoing this operation, because the recovery is just as important as the operation itself.
Okay, Dr. Freeman, Dr. McNally, it was a real pleasure having you on as our guest presenters tonight, and we want to thank you again for your time. Have a great evening.
Thank you so much for having us.
Thank you.